Thank you, Mark. Thanks for the invite, and good afternoon to everyone. It's great to join you here for the afternoon of this event, although I understand that I missed the exciting day. Mark, maybe next time, another year, another CICC in Toronto, but find a pleasant location, maybe the Caribbean or something, where it's not blowing snow outside in April. Anyway, we have only limited time for this talk, so I'll give people a quick overview on the low-risk cannabis use guidelines as a public health intervention project for legalization going forward. Just a little bit. Okay. What do I do wrong? The other one, this looks like an explosive device. Okay, I'm setting something up here. No? There we go. Disclosures, some public funding, only publicly funded talks, and I'm employed by public institutions. Believe it or not, I get paid for what I do. On to content. Just some high-level context. Cannabis use, prevalent in the population, primary prevalence of use among young people, of course, up to 1 in 3 people ages 15 to 25. That's where most cannabis use is happening. We know about the acute and chronic health risks from key reviews. I won't repeat them, go through a number of areas. Psychoactive effects, mental health effects, respiratory system, psychomotor control, impaired driving, and injuries, of course, relevant for burden of disease, and emerging evidence on maternal or reproductive issues and cardiovascular outcomes as among the main documented risks, acute and chronic for cannabis use. In terms of public health burden or burden of disease, you don't need to read all those numbers, but the essential information is that relative to licit and other illicit drugs, the burden of disease from cannabis is relatively limited. It's primarily driven by the fact that there's virtually no mortality. Nevertheless, there's a substantial burden of disease and negative impact on public health, which, of course, we're interested in reducing. Just a little bit for Canada. There's some information, some studies and estimates conducted that indicate that contrary to popular belief that most of the health problems are related to mental health issues from cannabis, really the main drivers of burden of disease in the Canadian population is related to motor vehicle accidents related to cannabis, because there we have quite a number of indirect deaths, but also quite a few injuries, and cannabis use disorders. Those numbers are quite sizable and happening, of course, also mainly in young or mid-aged populations, which are driving burden of disease from cannabis in the Canadian environment. This is how we got to legalization. I don't need to go into those details. And then task force report, the lead author sits right there. We're going to legalization, which is, of course, an entirely if it happens. I will really believe that when I see it in front of me. There's a few question marks still as of recent. But we're going, at least the plan is to go to legalization. And so from a public health point of view, this is, of course, a completely different situation. We're going to legalization not for the sake of legalization per se, but apparently, allegedly, in order to protect public health and safety. So we need to do things to ensure and accomplish these objectives, and that will not happen just by legalization in itself. We need to actively take measures, and legalization, of course, mandates and enables us in the public health and the intervention community in a unique way. We need to take measures to accomplish that public health and safety related to cannabis use will be improved. And there are a number of key angles to that. One of them is, of course, to try and get as many people to abstain from cannabis use. That's how you'll improve public health and safety to the maximum extent. But we know that about 1 in 8 adults, 1 in 4 youth or adolescents are active users, and those numbers are more likely to go up than to go down. At the same time, we know that quite a few key risks and harms related to cannabis use have already been increasing pre-legalization and are quite possibly about to go up through normalization, legal availability, etc. Really, from a big bird's eye perspective, the public health success of legalization will materialize if we manage to finding ways to get young people, the large number of young people who are exposed to cannabis or users, if we get them through the cannabis use phase of life, 15 to 30 years approximately, with as little acute or chronic health harm as possible. This is the main challenge to make legalization a success from a public health point of view. Just a couple of data bits to show how some of the harms actually have been increased. This is US data that indicates how the prevalence of daily, i.e. highly frequent users in the US has been doubling just over the last 2 years. And here are some curves about, this is from European data, about the increasing demand for cannabis disorder treatment in the European Union, also largely concentrated in young people, just as a couple of illustrations of how some of the problem indicators have actually been going up rather than going down even before legalization. So lower risk cannabis use guidelines as one tool to further public health gains or goals related to legalization. What's the rationale or conceptual basis? Conceptual basis for lower risk guidelines is that there's quite a bit of evidence that risk factors for key harms, acute and chronic harms related to cannabis use, are modifiable by user choices or behavioral choices among cannabis users. In other words, the risks or the harms, the health harms that we know about from cannabis use are not static or a given just because someone touches cannabis use or uses cannabis. It depends a great deal on how people use and certain choices that people make in regards to their cannabis use. That turned around, of course, means that on the basis of solid evidence, we can inform and educate cannabis users to make choices and behavioral choices that reduce those risks and reduce cannabis-related acute and chronic health outcomes. So in essence, and of course legalization enables us now to openly to do these things. We can openly educate and inform people as opposed to not talking about something that really involves illegal behavior and an illegal product. So low-risk cannabis use guidelines as conceptually, essentially as a form of evidence-based targeted prevention in the continuum of interventions between primary prevention that tries to get people to stay away from cannabis use and tertiary prevention, which is basically treatment for people who've developed problems. In the middle, targeting at those people who've made a choice to use and informing them on how to change their behavior to reduce their risks to accomplish minimal harm outcomes to health issues. There are, of course, similar interventions for other kinds of health-related behaviors. Low-risk drinking guidelines, for example, is one established tool in the health field related to psychoactive substances. And we have nutrition health guidelines, sexual health guidelines, of course. So this is a pretty standard intervention and approach in many other areas of health. How did we develop the low-risk cannabis use guidelines? As some of you may know, there was actually an original version produced and published in 2011. That, of course, was a very different time, socio-politically. So there wasn't much excitement and uptake of those, except for a few very courageous people and organizations that openly endorsed them at the time. But when legalization came on the radar, we took a systematic approach to completely revise and update. The science had emerged, of course, quite a bit. So we put together an international expert team. Bernard Lefol was one of them from Canada, people from 3 continents, led by the Ontario CRISM node, and we undertook a systematic review process. We did systematic searches and reviews on user-based or use choice-based risk factors for cannabis use harm outcomes. We reviewed the evidence, we quality graded the evidence through standard methods, and we developed a set of 10 recommendations by expert panel consensus approach that in themselves, in their full entity, form the lower risk cannabis use guidelines. The guidelines were published in the American Journal of Public Health earlier in summer 2017, last year. And I'll just give, so these are copies or image of the different papers, the original version and the new version in HEPH. They're of course available from me if you would like to have them or don't know them yet. I'll just give a very quick, given the time, cursory overview on some of the recommendations. So of course we have also on precautionary principles a recommendation that the best way to reduce or avoid risks related to cannabis use by abstinence, that's a no-brainer, and even in lower risk guidelines needs to be clearly stated. Age of use initiation, for example, based on scientific evidence, is greatly important. The younger people are when they begin to use cannabis, the more likely they are to develop acute but primarily chronic problems. So that's a very important prevention message, to delay initiation or onset of use to as late as possible. Of course, you can now make the argument ideally you delay it to age 75 or over, and then the risks for overall health harms are minimal. Very true. But at the same time, we need to be realistic of who's exposed and who is willing, or who are the people making the choice to use. So the critical thing is really whether people initiate at age 14 versus 16 or 17, for example, according to the science, makes quite a bit of difference in terms of outcomes. Choice of cannabis products, high versus low THC, clearly a factor for harm outcomes. The CBD combination comes into effect. But overall, the message, of course, clearly people have choices what products to use, and that will inform the level of risk for all sorts of different health outcomes definitely as well. That, of course, needs to go hand in hand with clear labeling, product, regulation, information. So illustrating the fact as well that these kinds of guidelines need to be backed up with information on products and other things from regulators and producers. We have a recommendation about cannabis use methods. So modes of administration have been diversifying a great deal. 20 years ago, everyone was using cannabis as basically smoking a joint or a hash pipe. Now we have vaping, cigarette devices, but we also have things like edibles, non-combusted intake. The evidence on those things is quite thin at this point, although we can say that at least for respiratory problem outcomes, pretty much anything that doesn't involve smoking combusted cannabis products is probably a safer alternative, not safe, but a safer alternative to other things. There's been very little uptake of this in the public health community so far. I think people are afraid to go there because it would involve concrete recommendations, and everyone says, well, there was crazy stuff with edibles in Colorado. Yes, there are some risks, especially among uninformed or vulnerable people, but once the evidence is out there and we clearly inform people about the different choices and what precautions to take, probably not smoking cannabis is a lot better for people's health than smoking it. Frequency and intensity of use from the data, very strong predictor, again, of acute and chronic outcomes. In other words, people who use daily very intensively are at much higher risk for all sorts of adverse health outcomes than occasional or infrequent users. Again, that's a great important prevention measure and message that needs to be translated. The evidence around those kinds of things is very strong. Cannabis use in driving, a no-brainer, clear association with increased risk for accidents, injury, and fatalities. Outside of the legal parameters, the science seems to say very clearly that a categorical abstention from driving within 5 to 6 hours of use is a minimal precaution. Of course, alcohol makes everything worse. So a very clear categorical message here: do not drive or operate machinery within 5 or 6 hours of use. Of course, it depends on a few subjective factors, but sort of as an overall clear recommendation, that's definitely right there. We've identified from the literature some special risk populations where we're advising at least temporary abstention as well. That involves women, pregnant women. This may, with more evidence, need to be extended to breastfeeding women. Potentially, science not clear on that one. We're also advising for people with a family or genetic history or predisposition for substance use related or acute mental health disorders to also abstain from use, because the risk of problems in those regards is clearly elevated from the science. And then finally, we're strictly recommending also for the above mentioned risks not to be combined. Also a bit of a no-brainer, but clearly if a 14-year-old initiates cannabis use with mainly high potency THC products and uses 3 times a day, that is clearly not a good idea for acute and chronic health outcomes and should really be avoided. So these are in essence the recommendations. Now, of course, these kinds of recommendations or guidelines are of little use if they're just published in the American Journal of Public Health and not effectively translated out into the community, user community, public health communities, and basically effectively applied and conveyed. That's kind of a science in itself. So we've undertaken quite a bit of efforts to do that kind of knowledge translation and that conveyance, and it's been actually surprising me even how successful things have been and how much uptake there has been of the guidelines. And I think it's a bit of an indication also that with legalization coming, there's been a real hunger and appetite for evidence-based tools and information to do something now in this new coming legal environment. So this was the launch of the guidelines in Ottawa. We publicly launched them in June of last year. You see a gentleman from actually the CEO of the Canadian Medical Association there. He was quite happy at the time with the guidelines. The Canadian Public Health Association and the Canadian Council of Chief Medical Officers all were there for the public launch. In the meantime, you see, I think now 8 leading national organizations have formally endorsed the guidelines. We had them endorsed by the Federal Minister of Health, and at least 2 provincial governments, Ontario and Quebec, have formally endorsed them as well. So that's a great formal endorsement success, and we're very, very happy for that to be the case, and of course are offering that tool in return to all these entities for active dissemination and application. We've produced several so-called KT products. Here's an example of what we call the user brochure. That's basically the guidelines sort of dumbed down into simple recommendation messages in a pamphlet form that can be distributed. We have a professional version for health professionals with a bit more meat on the bones and context. So these are just initial KT products that we've developed and made available, and it's actually been quite stunning, believe it or not. So these things are electronically available, but we've had requests from a wide range of organizations, and I think disseminated over 15,000 hard copies of these things, ranging from health and educational organizations, all the way to the RCMP and the Canadian Armed Forces. I think the Canadian Armed Forces requested a number of copies of those that would be the equivalent of, I think, 10% of everyone in the Canadian military using cannabis. So if that's reassuring to you that the people flying the military planes or driving the tanks are at least, you know, reading the pamphlet about don't smoke pot and drive, or they're waiting for 5 hours before they get into the tank, then I guess public health will be served on that front as well. We are doing a few exciting new things in terms of knowledge translation. So all I showed you so far was basically all done in a quick rush last summer before the launch. But we're developing some new KT versions, again, for users, but also special target groups. We're working with the CAMH and the Canadian Youth Council to develop a version just for young people. There's something in the works for post-secondary students. We just yesterday started a project with PHAC to develop KT strategies and resources for health professionals in the public health community for the guidelines to be rolled out. We're talking to a number of different of the provincial cannabis retail systems in Quebec and Ontario, for example, for the guidelines to be used and versioned for the coming retail systems, where, of course, online distribution will be an element. So we're working on digital and electronic online versions of the guidelines. And we also have plans for an interactive cannabis use risk self-check tool based on the guidelines that we're going to develop in the next little while. And I just today had a couple of exciting phone calls. We're working with people in Uruguay, the government in Uruguay, to produce a Spanish version that will likely be supported by PAHO and then hopefully rolled out also internationally to other countries and jurisdictions around the world, which is quite a nice success story, and it makes me actually quite happy and content, because if I go back to around 2009, we wrote a grant to CIHR basically proposing the concept and idea of the low-risk guidelines, and I think our score was like 2.6, and I told that it was an absurd, useless idea. And so here we are 10 years later, and times have changed in a number of different ways on different fronts. So that's the reference for the scientific publication. You can email me if you would like copies or the KT products. All of this indirectly now and directly supported by CIHR through CRISM. If you'd like any more information or any of the products, get in touch, and thanks for your time.